All right, if you are prepping for the NCLEX, you know that vascular disorders are a huge deal. So in this explainer, we're going to cut right through the noise and focus on the absolute must-know stuff that's going to help you crush these questions. Let's dive in.
You know, everything we're about to talk about really comes back to this one core idea: tissue perfusion. It is the foundation of everything. When your tissues can't get enough oxygenated blood, well, cells start to starve and organs begin to fail. If you can really grasp this, you'll understand the why behind every single sign, symptom, and intervention we're about to cover. It's that important.
So here's how we're going to break it down. We're going to look at 4 major ways perfusion can go wrong. You've got weakened vessel walls causing aneurysms, you've got runaway pressure with hypertension, you have critical blockages with peripheral vascular disease, and then the big one, the total system shutdown we call shock. This is our roadmap. Okay, first things first. You can't fix what you don't see, right? This part is all about assessment. It's about training your eyes to spot those critical red flags that basically scream that something is going very, very wrong with the vascular system.
Aneurysms can be tricky. A lot of times they're completely silent, but when they do show up, it's all about location, location, location. For an abdominal aortic aneurysm, what we call a AAA, the classic NCLEX sign, the one you absolutely have to know, is a pulsating mass in the abdomen. You might also hear about a gnawing pain or low back pain. Now for thoracic aneurysms, you got to think higher up in the body. So we're talking severe back pain, maybe some hoarseness or trouble swallowing because it's literally pressing on things it shouldn't be.
Now this is a whole different level of emergency. An aortic dissection isn't just a weakness. It's an active, catastrophic event. And the words patients use are a dead giveaway. The NCLEX loves these keywords, so listen up. A sudden, tearing, ripping, or stabbing pain. When you hear those words, your brain needs to immediately be flashing red lights. This is a code-level emergency.
Okay, this slide right here is NCLEX Gold. You are guaranteed to see questions that make you choose between these two. Let's make it simple. Arterial disease, or PAD, is a delivery problem. You can't get blood down to the feet. So think cool, pale legs, weak pulses, and that classic pain when walking, which we call intermittent claudication. And the key sign to look for is dependent rubor. That leg gets all red when it's hanging down. On the flip side, venous insufficiency is a return problem. You can't get the blood back up to the heart. This causes all that fluid to pool, so you see edema, achiness, and that telltale brownish skin discoloration called stasis stomatitis. See? 2 opposite problems with 2 very different looks.
So, how do we get a hard number on that arterial problem? How can we prove that blood isn't getting down there? Well, the answer is a little something called the ankle brachial index, or ABI. It's just a simple ratio, comparing the blood pressure in the ankle to the blood pressure in the arm.
And if that ratio, that number, drops below 0.9, boom, that's your diagnosis for PAD. It's a clean, objective number you have to know for the exam.
Okay, blood pressure stages. You've probably seen this chart a million times, but let's just focus on the real danger zone. Yeah, we go from elevated to stage 1 and 2, but look all the way down at that bottom row, hypertensive crisis. A systolic over 180 or a diastolic over 120. This isn't just a high number anymore. This is pressure that is actively destroying organs as we speak. This is another major emergency.
So, you've spotted the signs, you know something's wrong. Now what? What do you do first? This next part is all about your priority actions, the immediate, life-saving interventions. This is exactly where the NCLEX tests your clinical judgment.
Let's start with a really important what not to do. If you see that pulsating mass we talked about with the AAA, you do not touch it. Do not palpate it, ever. That's a super thin, weak wall, and if you push on it, you could cause a fatal rupture. This is a non-negotiable safety rule.
For that awful, tearing pain of an aortic dissection, the #1 goal is to take the pressure off that damaged artery wall, and fast. That means you get IV access immediately. Then you can give IV antihypertensives to lower the blood pressure and analgesics for the pain. After that, it's all about watching them like a hawk. Vitals every 15 minutes, continuous cardiac monitoring, and checking urine output every hour to make sure the kidneys are still getting perfused.
Now, for a hypertensive crisis, we're also using IV meds like nitroprusside to bring that pressure down. But here's the catch. We have to do it carefully.
The goal is to lower it by only about 20 to 25% in that first hour. If you drop it too fast, you risk cutting off blood flow to the brain and causing a stroke or shock. So it's a delicate balance, which is why you're checking that BP constantly and doing frequent neurochecks.
All right, let's talk meds. This table is pure gold, so let's focus on that NCLEX alert column, because that's where the questions are. For ACE inhibitors, that persistent dry cough is a classic side effect you have to know. For diuretics, you better be watching that potassium level because it can drop dangerously low. And for pretty much any anticoagulant or antiplatelet, what's your number one concern? Bleeding. Always bleeding precautions.
And here's a huge patient teaching point you can't forget. With beta blockers, you can't just stop taking them cold turkey. If you do, their blood pressure can shoot up to dangerous levels. We call it rebound hypertension, and it's a classic test topic.
Okay, so we've assessed our patient and we've intervened, but our job is definitely not done. This last piece of the puzzle is all about what you watch for next. This means monitoring after procedures and being able to spot the scariest complications before they become deadly.
After any kind of vascular surgery, like a bypass or an aneurysm repair, your number one fear is that the graft clots off. We call it graft occlusion. This is a true surgical emergency because all of a sudden, there's no blood flow past that point. And the signs are exactly what you'd expect: severe pain, a cool, pale, or even blue leg, and most importantly, absent pulses. You see this, you call the surgeon, period. Compartment syndrome is another limb-threatening emergency. This is where swelling inside a muscle compartment gets so bad that it cuts off its own blood supply. We remember the signs with the 6 Ps, but for the NCLEX, here's the one to really focus on: paresthesia. That numbness and tingling is often the earliest sign. Pulselessness? That's a very, very late sign. If you wait for that, it might be too late to save the limb. Now, with any DVT, the nightmare we're all trying to prevent is that clot breaking loose, traveling up to the lungs, and causing a pulmonary embolism, or PE. The signs are sudden and scary: sudden shortness of breath, chest pain, and that textbook feeling of impending doom. Your first moves are simple but critical. Sit the patient up to make breathing easier, call for help, and get ready to slap on some oxygen. Okay, that was a ton of information. So let's lock it all in with a super quick review of the most important things you need to take with you for your exam. If you only remember one thing about peripheral vascular disease, please make it this. For arterial problems, where you're trying to get blood down, you want the legs down. Think D for down and dependent ruber. For venous problems, where you're trying to get blood up, you want the legs up. Just think elevate for venous. It's a simple little trick to keep your intervention straight. All right, let's finish up with a question that puts it all together. You've got a post-op AAA repair patient. It's been 8 hours, and suddenly they have a super painful, cool foot with no pulse. So, based on everything we just went over, what is your single, most important, number one priority action? The answer is all about recognizing a surgical emergency and knowing exactly who to notify. Think it through. You've got this. That's how you're going to master vascular disorders on the NCLEX.